theory about hemolytic anemia. So it is a premature destruction of erythrocytes, and it often occurs in ICU patients. The etiology of hemolytic anemia is, we all know, autoimmune disease, warm or cold autoimmune hemolytic anemia, drug reactions, infections like malaria, Clostridium, viral hepatitis, Epstein-Barr, transfusion reactions, complications related to extracorporeal devices such as ECMO, Impella. Again, very important thing to remember, because we can get a patient on ECMO in the MCQ, and they may ask why the patient is developing anemia. And there you must remember, hemolysis can be one of the very important reason of developing anemia in such patients. Then certain toxins, bone marrow suppression due to sepsis, and underlying conditions such as SLE and ELF syndrome, they all can cause hemolytic anemia. So how to remember which anemia will cause or which history is important for analysis of autoimmune hemolysis? So you must see, there might be some clues given in the MCQ, like if there is a history of recent blood transfusion, then it could be because of transfusion reaction. History of recent fever or travel, then viral hemorrhagic fever or malaria can be reason. Septic shock, again very important. Septic shock itself can lead to hemolysis because of presence of DIC. Then if any new medicine has been added, that must always be seen into it, like 5-FU, methyl dopa, quinine, diclofenac, penicillins, especially piperacillin, cephalosporins, and many others. So patient coming to you with sepsis, the patient has been prescribed any of the penicillin or cephalosporin, and the patient is now having anemia. So, it could be one of the reasons. The history of pigmented gallstones can suggest chronic hemolysis, history of recent infection, history of stress. So, this is important for patients who are having G6PD deficiency. So, surgery, infection, or exposure to an oxidant like medicines which can cause G6PD precipitation, leading to this autoimmune hemolysis. Then, if this patient is giving you history of weight loss and night sweat, then you have to rule out hematological malignancies. And arthralgia can represent autoimmune disease such as SLE or infective procedure of Bartonella. Important points in physical examination will be that jaundice is mandatory, bilirubin will be raised. Mostly it will be unconjugated one. Dark urine usually suggests conjugated bilirubin is present excess, whereas jaundice, the absence of pigmented urine, suggests that the bulk of bilirubin is unconjugated. So, in an autoimmune patient, this hemolytic anemia patient, you will see there is an absence of pigmented urine, or it will be very less. Then the patient may have features of splenomegaly, which is representative of extravascular hemolysis, and feature of arterial insufficiency can be there, especially in patients who are having sickle cell anemia. Then these are some laboratory features. These are the clues from the blood smear. These are very important. In exams, it is very commonly asked. So you have to remember, especially these six slides and these six problems. Okay. So schistocytes, very much classical of microangiopathic hemolytic anemia, because in microangiopathic hemolytic anemia, your RBCs are getting fragmented. Okay, so you will see fragmented RBCs in the PBS, so schistocytes. So classical of MAHA, and it includes TTP, HUS, and DIC. Then second is microspherocytes. So this you can see spherocytes. So this is the classical of autoimmune hemolytic anemia. In fact, we had one patient today with us, presented to us with jaundice, severe jaundice with mostly indirect hyperbilirubinemia, and PBF showed spherocytes, and the patient has direct Coombs test positive. Okay, further evaluation is ongoing why this is happening, but we had a patient today. So spherocytes can be seen, and then sickled red cells, you can see flat and different flattened RBCs. This is sickled cells, and you can also see target cells. Then bite cells. So these are bite cells. So bite cells are commonly seen in G6PD deficiency. Basophilic stippling is seen in thalassemia, alcohol abuse, and ring sideroblast. This is ring sideroblast. It is seen on bone marrow aspirate, and it is seen in various congenital disorders and myelodysplastic syndromes, okay, or in copper deficiency. Again, very important. So cystocyte, microspherocytes, bite cells, residuals, you can be asked anything. Okay. So morphological RBC abnormalities you have to remember. Then you will usually see patients having high reticulocyte count because it is a marker of normal bone marrow. Usually hemolysis is happening outside bone marrow. So bone marrow, when it sees that there are signals of low hemoglobin, it will produce. So reticulocyte high count is usually suggestive of anemia outside bone marrow. Then patient will can have high LDH, although it is not a specific marker of hemolysis, but very commonly seen. Haptoglobin is usually low because hemolysis is leading to increase in iron in the blood. Okay, so when the iron is very much high in the blood, so that has to be transported. So haptoglobin levels become reduced. Okay, and you may also see that free hemoglobin will be there, and you can also see hemoglobin urea. Okay, so these are all the signs of hemolytic anemia. So further lab features will be this Coombs test. You can do a direct Coombs test and indirect Coombs test. So direct Coombs test is used for differentiating between warm and cold hemolytic anemia. In warm hemolytic anemia, it is caused by antibodies which are maximally active at human body temperature. That is why it is warm, and usually caused by IgG type of antibodies. Okay, and hemolysis usually caused by IgM occur usually in cold conditions. Okay, so uh, this is warm hemolytic anemia, cold hemolytic anemia. So causes of warm include idiopathic primary hemolytic anemia, viral infections like HIV, hemolytic anemia, and lymphoproliferative disorders like CLL, lymphoma, multiple myeloma, Waldenstrom microglobulinemia, and autoimmune disorders like SLE. These all cause warm. Cold is caused by post-infectious cold agglutinin disease like syphilis, post-viral, mycoplasma, EBV, adenoviruses, influenza viruses, because it is mostly happening because of IgM. And paroxysmal cold hemoglobinuria, that is usually again post-viral hemolytic anemia. So clinical management. So management principles in patients who are having fulminant acute hemolysis, plasmapheresis is indicated. Okay, so this is grade 1, 2 indication in many of the hemolytic anemias. Plasmapheresis, emergency situation, you can do it. Okay, but this does not do anything to the underlying autoantibody production. So for that, you need to first identify the disease and you have to give a specific treatment for that. Okay. Rituximab, again, very important monoclonal antibody, usually given in patients of cold hemolytic anemia, but it is more effective in warm disease as well. And eculizumab, a very new drug, and again, it can be asked in exam. It is a monoclonal C5 antibody, and it has been shown to be effective in various case reports like atypical HUS and PNH. Okay, so we had another patient of atypical HUS where we used eculizumab. So this can be asked in exam as well. Specific treatment for warm hemolysis. So, if the patient is in crisis situation, we go for plasmapheresis, and then we have to also think about corticosteroids, splenectomy as a second line treatment, and this who fails steroid and splenectomy, we may go for cyclophosphamide or azathioprine. IVIG is not strongly indicated, but some reports show benefit. Danazol is an old medicine not used in warm hemolysis anymore. And treatment for cold hemolysis is avoid cold. That's the most important thing. Any other other treatments are not very much effective in mostly because it is post viral. So you have to think about avoiding cold exposure, give time so that IgM levels reduce, and also you have in crisis you may go for flex. Just a little bit about intravascular versus extravascular hemolysis. So intravascular hemolysis is that the cells being destroyed inside during their transportation in the vessels. Okay, so breakdown products will be seen in biochemistry and clinically. So free hemoglobin will be there, hemoglobin urea will be there, haptoglobin reduced, LDH is levels so very increased, and red cells will be visibility abnormal on microscopy. So PBF will be very much positive. Extravascular is that is in these systemic features are not there. So most of the hemolysis occurs in macrophages of the liver and spleen. Okay, so there will be no free hemoglobin. Haptoglobin is usually not lowered. LDH may be raised but not very much high, and PVF is usually not showing many features. Okay, so this is the difference between how to identify intravascular and extravascular.